Hi, I'm Lauren Henke, and we're back today for another episode of the NRG Oncology podcast with my co-host, Dr. Stephen Chun. Today, we're catching up with Dr. Loren Mell, who is principal investigator of the recently activated NRG Oncology HN016 for patients with head and neck cancer who cannot receive standard cisplatin chemotherapy. As a nationally recognized expert in head and neck and gynecologic cancers, Dr. Mell is a member of the NRG Oncology Head and Neck Core Committee and the Cervix Vulva Subcommittee. He also serves as chief of the Head and Neck Service and vice chair of clinical and translational research for the Department of Radiation Oncology at the University of California, San Diego.
Dr. Mell, welcome to the NRG Oncology podcast. As I understand it, about a third of patients with head and neck cancer can't get cisplatin, which is generally considered the standard of care with radiation because of either their age or other medical comorbidities. And by the way, I happen to be one of those people who wouldn't do very well with cisplatin because I have moderate sensory neural hearing loss. So in cisplatin-ineligible patients, for the past 20 years, we've used another antibody called cetuximab. I believe it targets the epidermal growth factor receptor. And we add it to radiation based upon a landmark clinical trial by James Bonner. Can you start off telling us how cetuximab works with radiation and what are the outcomes like for these patients treated with radiation and cetuximab that we're looking to change the game?
As you mentioned, radiation and cetuximab is commonly used for patients who cannot receive cisplatin due to various contraindications, age, comorbidity, hearing loss, renal insufficiency, and so on. Cetuximab is an effective radiation sensitizer, and that's been proven in both preclinical studies and in the randomized trial that you mentioned by Dr. Bonner and colleagues that showed that when it was added to radiation therapy, locoregional control and survival were better. So on the basis of that, cetuximab, which is FDA approved for treatment of locoregionally advanced head and neck cancer in combination with radiation, is commonly used for these patients. Cetuximab has thus been used in most clinical trials as the go-to standard for this unique population. We are interested in comparing and establishing the standard of care because over the past decade or so, carboplatin-based regimens, including carboplatin and paclitaxel, has become more commonly used outside of trial setting, but in standard clinical practice. This trial seeks to compare these two regimens and establish which of the two should be the standard for this population going forward.
In HN016, for patients who can't get cisplatin with radiation, you're pitting carboplatin and paclitaxel up against standard cetuximab with radiation. We've talked a lot about carboplatin and paclitaxel on this podcast before in other episodes, which is commonly used for gynecologic and lung cancers. What are the lines of evidence leading up to this that carboplatin and paclitaxel will work with radiation in the head and neck cancer setting? And how is HN016 specifically designed to test that?
Yeah, great question. So carboplatin-based regimens have been used in various clinical trials and in the community setting as well in published population studies or institutional studies that support its effectiveness. Carboplatin and 5-fluorouracil, for example, was a commonly used combination regimen in European trials, and there are several studies that support its use. Over the past decade or so, taxanes have been used in this population. There is a well-known study from India, for example, that used docetaxel for patients who could not get cisplatin and showed that that regimen with radiation was better than radiation therapy alone. Carboplatin and paclitaxel, just empirically, is now the most commonly used regimen for cisplatin-ineligible locoregionally advanced head and neck cancer. However, the clinical trial evidence for that regimen has lagged. There are a number of smaller institutional studies that have used various dosing schemes. More recently, a paper from Memorial Sloan Kettering that established that results with this regimen are very good and very attractive, but that was a single institution study. So we're seeking to validate those findings in a multi-institutional clinical trial.
As Loren alluded to, carboplatin and paclitaxel have been around for a long time. In the 1960s, paclitaxel, I believe, was isolated from Pacific yew trees, and as one of the triumphs of organic chemistry, was synthetically produced and found to kill cancer. Carboplatin, on the other hand, was developed in the 1970s essentially as a less toxic version of cisplatin. For decades, we've been using carboplatin and paclitaxel concurrently with radiation for gynecologic cancers, lung cancers, gastroesophageal cancers. With my locally advanced non-small cell lung cancer patients, many of them are poor candidates for high-dose cisplatin or even low-dose cisplatin. And we figured out pretty early on in the early 2000s that we could use carboplatin and paclitaxel with radiation, and patients did quite a bit better. Why has it taken us so long to explore carboplatin and paclitaxel with radiation in head and neck cancer when it was explored decades ago in so many other disease sites with radiation?
That's a valid question, a somewhat complex one. One has to do with the various alternatives that have come out in that time frame that you're describing. Cetuximab is the first example where the EGFR inhibition was shown to be an effective strategy, and therefore that has established that as more or less the de facto standard. What we've learned over time, however, is that taxanes are effective in their own right for this disease. And from various studies that have compared cisplatin head-to-head against cetuximab, we know that cisplatin is superior to cetuximab, at least in oropharyngeal cancer. That's well established. So the thought is that carboplatin may approximate that effect in patients who can't get cisplatin for various reasons. So there are reasons to want to give carboplatin. The data so far, though, for single agent carboplatin with radiation are not great. And given the known effectiveness of taxanes and the known safety of carboplatin and paclitaxel in combination with the radiation in head and neck, that's how that paradigm has evolved. Over the last 10 years, immunotherapy came forward and was a very attractive strategy to try to replace the effective cisplatin for cisplatin ineligible patients. But in multiple trials, when it was compared head to head with cetuximab, immunotherapy checkpoint inhibitors did not improve outcomes, unfortunately. So that has led us back to this place where we have carboplatin and Taxol out there, used often in the community, but based more or less on circumstantial arguments rather than rigorous scientific data.
Hearing you explain this, it's almost as though the progress made with cetuximab and then the general progress made with checkpoint immunotherapy were enough progress in terms of cetuximab to almost sort of slow being able to ask this more historic question. And now that the dust has settled, perhaps with the excitement around concurrent immunotherapy, we have returned to exploring old faithful options, if you will.
Well, that's right. And I think that there's a sentiment that given what we know now, that carboplatin and paclitaxel may be a more effective regimen than cetuximab. Of course, in head and neck cancer, we have a big divide between HPV-associated or P16 positive cancers and HPV negative cancers, which tend to have a worse prognosis. It's really in the HPV-associated cancers where the superiority of cisplatin to cetuximab has been shown emphatically. So there's a strong feeling that cetuximab may not be all that effective for HPV-associated disease. However, it should be noted that in the Bonner trial that you mentioned, they actually looked at that and found that cetuximab seemed at least as efficacious in the HPV-associated cancers. But based on that strong evidence from other trials such as RTOG-1016 and the de-escalate trial, the ARTScan trial, numerous trials have shown that cisplatin is better than cetuximab for that group. The assumption is maybe that platinum-based regimens would be superior for that group.
So how is HN016 designed to test this question? What's the primary endpoint? How many patients? What are the arms?
The primary endpoint of the trial is progression-free survival. There are two arms to the study. It's a phase 3 trial that will enroll 454 subjects, randomized evenly between the two arms.
Let me ask a theoretical question. Let's say HN016 is positive and it shows that carboplatin and paclitaxel are indeed better than cetuximab. You alluded to this earlier, but I want to know, how will we know that it's the combination of carboplatin and paclitaxel responsible rather than just, say, carboplatin or paclitaxel alone with radiation?
There isn't a way to tease that out in this trial since the two drugs are being given in combination, so we won't necessarily know that. We do know, however, as a whole, these patients tend to have a poor outcome. This trial, even amongst the HPV-associated cancers, we're selecting for the more advanced stages. So in that relatively more favorable group, we might expect 5 years survival around 70%. In the HPV negative group, though, the outcomes are much worse than that. So there's a strong rationale to give multi-agent therapy since we know that independently these agents are effective, and we know in combination that regimen is tolerable for this population. So if anything, these patients are in need of escalated treatment. It's just that we haven't been able to establish that more therapy is actually better for them.
So let me ask a quick question as follow-up. Let's say a patient is enrolled on HN016. They're assigned to receive carboplatin and paclitaxel, but they have unexpected toxicity. Could you potentially de-escalate one of the two agents, or do you have to drop both?
So each can be de-escalated independently according to institutional standards. One of the advantages with carboplatin and paclitaxel is it's a very familiar regimen for medical oncologists to give. They deliver it in a variety of settings, so there's a lot of institutional experience with using this regimen and adapting to observe toxicity. And that is the case here. We allow for treatment modifications to be given essentially along institutional standards. So one thing to point out about HN016 is that it's a, quote, pragmatic trial, and it's one of the first to be done through NRG. What that means in practice is that the protocol is meant to be streamlined in terms of its data collection, the density of data that we're collecting, but also there's a deference to institutional standards for most things that aren't critical to the scientific question at hand. In this case, carboplatin paclitaxel is commonly used in the community as well as academic centers. And we're interested in just at the end of the day, which of the two regimens yields better outcomes for this group.
We've talked a lot about the rationale and the potential benefits of carboplatin paclitaxel for these cisplatin-ineligible patients. But for a patient looking to participate in HN016, what differences might you expect to see in terms of side effects between carboplatin and cetuximab, and any potential risks that patients should know about going into this?
So these have quite distinct side effect profiles, as you might imagine. Cetuximab classically is associated with a rash. Most patients will get that. There are also some patients who, based on having particular enzyme deficiency, are not able to get cetuximab. That tends to be regionally confined. Cetuximab increases mucositis and swallowing difficulty over patients who receive radiation alone. But carboplatin and paclitaxel do that as well. So mucositis rates will be a key endpoint that we'll want to compare, since that's such a common toxicity that patients have to contend with. Carboplatin actually also will cause myelosuppression to a greater degree than other agents, including cisplatin. So that's one thing that we'll have to follow. Taxanes, of course, are associated with alopecia and can independently lead to neurotoxicity. So that's another side effect that we're going to have to follow closely.
Potentially change in hair loss and neuropathy, but also at the exchange of potentially less, often clinically significant rash.
Yeah, and for this group, quality of life starts to become such a relatively important consideration, and where we do have instruments in the trial to evaluate that. That will be a key secondary endpoint that we'll want to compare in the study.
All this being said, I don't think that there are going to be huge surprises with carboplatin and paclitaxel with radiation and HN016, given how much we know about this strategy for, let's say, gynecologic and lung cancers. Before we let you go, for setters and investigators out there who are looking to open and participate in HN016, what should they know, and what kind of resources are out there to facilitate?
I don't think that there will be huge surprises in terms of side effects or tolerability. This is a regimen that's been tested and published on, albeit not with this cooperative group setting. I think that the reasoning for the study is important here because in order to advance the field, it's important for our group and our community to have a good handle on what is the optimal comparator regimen. What we have right now is a disconnect between cetuximab being used predominantly in clinical trials and carboplatin and paclitaxel being predominantly used in community and outside of trials. And what we're trying to reconcile is that gap so that new agents come along, we have a clear standard against which to test. As far as resources to facilitate the trial, NRG Oncology is actively puts out information about the study in support of its members. This is designed to be a relatively simple trial to conduct and ideally a speedy one so that we can get to this answer quickly. So I think this among trials would be an attractive one to run at centers that see a good number of head and neck patients. As it stands, we don't really have a clear handle on the standard of care.
Sounds like between the pragmatic design in terms of the question, people's comfort with these regimens, and also the pragmatism of the way data is being collected, that this really should hopefully be a success. So thank you again for coming on the NRG Oncology podcast. And I really hope HN016 is a success in an area that we haven't seen any real changes since the Bonner study in 2006, which was actually the year that I graduated high school. So.
Well, I greatly appreciate this opportunity to talk about the study and to put this information out there to the community. It's wonderful.
Today we had Dr. Loren Mell from the University of California, San Diego, speaking about the recently activated NRG Oncology HN016 trial for cisplatin ineligible patients with cancers of the mouth, throat, and voice box. By the way, did you know that you can donate to NRG Oncology? NRG Oncology is a nonprofit organization, and NCI funding alone does not sustain our activities that largely depend on volunteerism. Tax-deductible contributions at nrgoncology.org/about-us/support-NRG, no matter how small, will help us move the needle forward for our cancer patients who desperately need better treatments. The NRG Oncology Group is supported by funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.